conference organized by the Pediatric and Adolescent Gynae unit from Department of ONG, HCTM and HPKK. So Dr. Loh Sweet Yi has done a lot, put in a lot of hard work in this. Yeah. So the title is A Woman's 22-Year Journey with Primary Amenorrhea and Cyclical Pelvic Pain. So Dr. Loh will be discussing the case, presenting the case with all of you. There are a lot of aspects of interest in this case, yeah, not just the management-wise, but also the ethical issues and so forth. So Dr. Loh Sweet Yi Esther is, or we call her Esther, is a consultant actually, ONG, and she graduated from her master's in 2019 and completed her fellowship in PAG end of last year. So PAG is Pediatric and Adolescent Gynecology. So it is a subspecialty in ONG, like infertility, like urogyne, like what else? Maternal fetal medicine. Yeah. So in pediatric adolescent gynecology, we manage cases, obstetric and gynae issues in all females up to the age of 21. That means we see babies, we see prepubertal kids, we see adolescents, and we see a lot of young women. We mostly manage menstrual problems. So girls can come with no period at all, hardly any period, too much period, or painful periods. We also manage girls with abnormal reproductive tract, Mullerian abnormalities, no vagina, vaginal septum, cervical agenesis, abnormal uterus, yeah. And then of course we manage things like vulvar vaginitis, sexual abuse, and teenage pregnancies. Okay, so Dr. Loh Sweet Yi Esther is part of our unit, and she will present this case. And we have also invited our pathologist, Dr. Azyani Yahaya, who has been working in UKM for the past 15 years. So she specialized in pathology since 2014 and subspecializes in anatomical pathology. Okay, so we will open to discussion, and inshallah Prof. Nur Azura will be coming as well. So she is also part of our unit, a senior consultant, and our previous head of department. Okay, so with this, I hand over to Dr. Loh Sweet Yi to start. Thank you.
Hello and good morning, everyone. Okay, my name is Dr. Esther, and today we will be discussing a case of a woman's 22-year journey with primary amenorrhea and cyclical pelvic pain. All right, so this is the case of a 38-year-old Miss A. And she first presented at the age of 16, which is 22 years ago, with the chief complaint of primary amenorrhea. And this was associated with cyclical pelvic pain for 1 year and bilateral hearing loss. On physical examination, she was underweight. She had normal secondary sexual characteristics, which is evidenced by the presence of axillary hair, breast tenderness stage 4, pubic hair tenderness stage 4. And on abdominal examination, there was only suprapubic tenderness, but no palpable mass. And the pelvic examination revealed normal external genitalia, but a blunt-ended vagina, which was only 1 centimeter in length. So further investigations were done, including laboratory investigations and the hormonal profile, which includes serum follicle stimulating hormone, serum luteinizing hormone, serum estradiol, were normal. Her karyotype was also normal at 46XX. When we did ultrasound for her, we found that there was a single uterus measuring 4 times 2 times 2 centimeter, normal ovaries, but there was cyclical hematometria, which is the collection of blood in the uterus, measuring 1.6 times 1.4 centimeter, and there was cyclical free fluid at the pouch of Douglas. This was supplemented with an intravenous urogram, and she was found to have an absent right kidney with a normal left kidney. So what is your provisional diagnosis at this juncture? You are absolutely right, it's MRKH, okay? But how did you get to this diagnosis? All right, so first we have to approach the chief complaint, which is primary amenorrhea. So primary amenorrhea is defined as the lifelong absence of menses. It occurs if menarche has not occurred by 15 years of age or 3 years post-TLACI, TLACI meaning the development of the breast buds, in the presence of secondary sexual characteristics. However, in the absence of secondary sexual characteristics, primary amenorrhea is defined as the absence of menarche by the age of 13, okay? So this is an approach adapted from American Family Physician 2013. Okay, if you can see here, you start by performing a history and physical examination. You might want to take some blood investigations, including your pregnancy test, serum LH, FSH, TSH, prolactin. You might want to do a pelvic ultrasonography. And if a uterus is present, you will drop down to the next parts of the flow chart. So if a uterus is present, then you will have to evaluate your serum FSH and serum LH levels. If there is low FSH and LH, this is called hypogonadotrophic hypogonadism. Okay, and the causes are functional hypothalamic amenorrhea, constitutional delay of puberty, and rarely primary gonadotrophin releasing hormone deficiency. All right, if there's normal FSH and LH levels, this is called eugonadotrophic eugonadism. Okay, and this you can consider outflow tract obstruction. Okay, if there is elevated FSH and LH levels, this is called hypergonadotrophic hypergonadism, okay, and usually the cause is primary ovarian insufficiency. So in this patient who has normal FSH and LH levels, what do you think the diagnosis is? Outflow tract obstruction, which is MRKH, because she has normal karyotype of 46XX, eugonadotrophic eugonadism, okay, and she has normal secondary sexual characteristics and external genitalia. So this is MRKH. So remember, MRKH is Mayer-Rokitansky-Kuster-Hauser syndrome. It is a congenital disorder characterized by agenesis or aplasia of the uterus and upper part of the vagina in females with normal karyotype 46XX. This is also known in literature as Mullerian aplasia. The prevalence is very low, 1 in 5,000 live female births. So this is considered a rare disease. So as you can see here in this picture, there are normal ovaries, normal fallopian tubes, but there is an absence of a normally formed uterus and absence of the upper part of the vagina. All right? So generally, as I mentioned earlier, women with MRKH have normal reproductive endocrine function. They have normal signs of TLACI and pubarchy, and they typically present with primary amenorrhea. Their external genitalia appear normal. And this can be categorized into type 1 or type 2 MRKH. Type 1 MRKH is when they only have the gynecological features, and in type 2 MRKH, they may have associated pathologies in the other parts of their body, including the spine, and in this case, for this patient, the kidney and the hearing loss. Okay, she has mixed conductive hearing loss. So our principles of management for MRKH, we follow a systematic framework whereby we look at puberty. They will have normal puberty. For menstruation, they will not have menstruation because there's an absence of a normally formed uterus. We can help them to have normal sexual function by creating a new vagina, which is a new vagina, either surgically or non-surgically using vaginal dilators. And if they are keen for fertility and pregnancy, these are the following options for them. They can either go for adoption or gestational surrogacy, but this is not allowed in our country. And in the future, the very near future, we may be able to do uterine transplantation in Malaysia. There are many countries already doing successful uterine transplantation. Not forgetting that these patients also have psychological and psychosexual issues that must be addressed and referred accordingly. And we need to do surveillance and management of their comorbidities. Like in this patient, her hearing loss and also her absence of kidney must be referred accordingly to the physicians and the surgeons. All right, so this is a picture of a patient with MRKH, not this patient, which shows that instead of a uterus in the center, okay, we find that there's a fibrous cord instead. And you will find that the uterus is underdeveloped on the left and right side, and there's normal fallopian tube and normal ovaries. Here you have a smaller uterus on the right side with absence of fallopian tube, but there is a normal ovary. Okay, so this is what it looks like in the pelvis of a patient with MRKH. So moving on to our patient, how does it become a mystery? All right, so we have already diagnosed her as having type 2 MRKH at the age of 16. But what explains her cyclical pelvic pain if she does not have a normally formed uterus and does not have menstruation? Wouldn't you agree that it's very mysterious? All right, so further investigations and finally a first diagnostic laparoscopy at the age of 16 confirmed that she had type 2 MRKH. So for her cyclical pelvic pain, she was just given non-steroidal anti-inflammatory drugs on a PRN basis. However, throughout the years, she continued to have cyclical pelvic pain, and eventually 10 years later, an MRI pelvis was done and retrograde menstruation was seen. And thus, patient was started on continuous oral contraceptives to suppress her menses so that she will not have the cyclical pain anymore. Unfortunately, this did not work. She continued to have cyclical pelvic pain requiring analgesia, and in 2023, she required a third diagnostic laparoscopy. And this time, we found endometriosis and a right ovarian endometrioma. And her serum CA125, which is normally elevated in endometriosis, was raised when it was previously not raised. Don't you find this very surprising? Okay, so this is a picture of her laparoscopy intraoperatively. Remember, in the middle, there's no uterus and there was a fibrous, only a fibrous band. You can see on the left side that there is a rudimentary uterus with normal ovary, but on the right side, you will find that there is clubbed fallopian tube, all right, and there's already hydrosalpinx, swelling of the fallopian tube. And can you see all these endometriotic spots? So these are all endometriotic spots that have developed on this side of her rudimentary uterus, tube and ovary, and in fact she had a endometrioma on the right side, and you can see that there's free fluid in the pelvis, which is evidence of retrograde menstruation. So how did this happen? So we came up with the provisional working diagnosis that she had type 2 MRKH syndrome with a functioning rudimentary uterine remnant. Already she's a very rare case, 1 in 5,000. Now she's even rarer in the rare cases, okay? And also endometriosis with endometrioma and adenomyosis. Our differential diagnosis would include Mittelsmith's and premenstrual syndrome. So a little bit about endometriosis, just to jog your memory. Endometriosis is based on the histological identification of endometrial tissue at ectopic sites, meaning out of the uterus. Commonly, it is at the pelvic organs, peritoneum, and ovary. In rare cases, ectopic lesions can even be found in other organs such as kidney, bladder, lung, or brain. And you can achieve the diagnosis clinically or by laparoscopic intervention and followed by histological confirmation of endometriotic tissue. The prevalence is about 10%, with many patients experiencing pain and infertility. And currently, the implantation hypothesis by Sampson is the most accepted hypothesis about the pathogenesis of endometriosis. Okay, how about a functioning rudimentary uteri and endometriosis, meaning in MRKH, what is the prevalence of having functioning rudimentary uteri and then having endometriosis? So MRKH syndrome with functional uterine remnant is a rare subtype of such obstructive anomalies, and during the earlier stage of embryogenesis, there's a failure of Mullerian duct development, resulting in the functioning endometrium not connected to the normal outflow tract. So if you remember our approach to primary amenorrhea, in eugonadotrophic eugonadism, you must think of outflow tract obstruction, and this is one of it, all right? So about 40% of patients with uterine remnants have some endometrium, meaning that we cannot exclude that they all don't have endometrium. And about 50% of these patients experience cyclic pelvic pain-like menstrual symptoms, but without bleeding, okay? However, it is mentioned that these uterine remnants, because they are so small, hypoplastic, and underdeveloped, they have a low proliferative ability and thus result in postponed bleeding and slow development of disease. So the continuous bleeding from the uterine remnant will form the hematometra, which is a collection of blood in the uterus, and reflux to the peritoneal cavity through the ipsilateral fallopian tube. So does that explain what you saw on the laparoscopic images? Okay, good. All right. So we're going to look at 3 papers, okay, in 2019, 2013, and 2021 especially about patients who have MRKH and endometriosis. Okay, this is just a tidbit. All right, so we found that they actually looked at many papers, okay? They looked at many papers, and some of them show the histological lesion, but some of them did not. All right, so whatever I present later will be a conclusion or a summary of what was presented or found in many of these case reports published between 1981 to 2017. All right, so basically they found that the sensitivity of ultrasound in the detection of uterine remnants is low. As you can see, in this patient at the age of 16, there was a visualization of uterus, but they only visualized one when she had one on the right and one on the left, okay, the remnant uterus. However, it is found that MRI is superior with a high correlation of MRI findings with laparoscopy, and that was evidenced in this case, all right? So they found that when they did MRI, and in this study, when they did MRI and detected a functioning endometrium on the MRI, which was what happened in this patient, they found that 41 out of the 39 patients and 15 out of the 41 patients had endometrium proven histologically. So the diagnosis of uterine endometrium by MRI agreed in 85.4% of the cases. All right. The other thing is about the CA125. So it appears in this large study in China in 2021, where they look at all the women who have MRKH with functional uterine remnants and associated endometriosis. The CA125 was the only blood investigation, or the only investigation which was significantly elevated compared to those without endometriosis. So it might be useful to use CA125 as a surveillance biomarker. Okay, so in all the 202 cases that were studied in this study by China of women with MRKH with a unexpected functional rudimentary uteri, they found that 177, most of them were asymptomatic. And in the asymptomatic group, there was in the asymptomatic group, eventually 18 of them had clinical symptoms. And out of these 18, 16 of them had a resection of the uterus. That means they had to have it removed. And this was confirmed to have a functional endometrium. And eventually, even the two who refused for the hysterectomy or the resection of the rudimentary uterus eventually ended up with a resection of the uterus in a later period. So this is also what happened to our patient, okay, as you will see later. Now this is another tidbit for you to know that there are case reports of non-resection of the rudimentary horn, whereby there are people in other parts of the world who have done very, very novel cases of isthmo-neovaginal anastomosis and uterovaginal anastomosis, whereby they try to create a new vagina and they try to connect the functioning rudimentary uteri to the new vagina. But these are very, very novel and rare, okay? So another tidbit for you. So eventually what happened to Miss A? So despite the absolute uterine factor infertility, the patient was still keen to conserve her functioning uterus. As you remember, MRKH is associated with a lot of psychological and psychosexual issues. So we did a drainage of the hematometra and evisceration of the ovarian endometrioma, and then we continued to give her continuous COCP, but she still did not respond, and eventually she had to have resection of the rudimentary uteri, as was seen in the cases in China anyway. Okay, hereby I would like to invite Dr. Azyani to present on the pathology of the resected uterus. Tak nampak pula. Okay, click to exit. So I have to do this one. Where's yours? Okay.
Okay, Assalamualaikum and good morning. I will be presenting on the HPE findings of this patient. Okay, on the 27th of June 2023, I received specimen labeled as right hemiuterus and right fallopian tube. So grossly, we received an untagged right hemihysterectomy specimen, consists of a small lobule of uterine tissue and a separated fallopian tube with presence of embryo. And the right uterus measures about 4 centimeter in the largest dimension. Grossly, there was no obvious lumen. And then there is an irregular area, which we think was resection margin. Okay. And serial sections of the specimen show a small central cavity and thin endometrium measuring about 1 millimeter in thickness. There was no hemorrhagic spots or any suspicious mass seen. The fallopian tube measures about 40 mm in length and 6 to 8 mm in diameter, and it was unremarkable grossly. There was no ovary included, and representative sections was sent. Okay, so this is a cut section of the uterus. Okay, as you can see, this is the cavity of the uterine cavity. Okay, and there is lining by endometrium. Okay, and this is the myometrium, which is the smooth muscle of the uterus. Okay, and then we see a small spot of adenomyosis. Okay, okay, higher magnification. This is the uterine cavity. Okay, and then this is the endometrium. And the endometrium is in proliferative phase, evidenced by these tubular endometrial glands, and it is lined by uniform endometrial tissue, endometrial cells. Okay, and this is the stroma, which is cellular. Okay, there is occasional intraepithelial mitosis seen, okay, within the epithelium, which is expected in a proliferative phase. Okay, the foci of adenomyosis seen, it is composed of endometrial glands as well as the endometrial stroma, and it is seen within the myometrium. Okay, so we call this adenomyosis. Okay, another section taken from the uterus. This is endometrial cavity with the endometrium lining, and this is another foci of adenomyosis seen within the myometrium. Okay, higher magnification. So this is adenomyosis composed of endometrial glands and stroma, and we can see evidence of hemorrhage, as you can see here, extravasated red blood cells. Okay, and then there's also this hemosiderin-laden macrophages, which has engulfed the byproduct of the red blood cell, hemolyzed red blood cells. Okay. Okay, another section shows endometrial cavity with the endometrial lining, myometrium. Okay, this is the higher magnification. Okay, you can see well-spaced tubular endometrial glands. This is a section from the fallopian tube. It was unremarkable. So you can see here this fallopian tube, the lumen. It is lined by ciliated columnar epithelium. There is they form infolding into the lumen, okay, and then the stroma is a bit edematous. There's no endometriotic foci seen here. Okay. Again, higher magnification, fallopian tube lined by ciliated columnar epithelium, okay, and they form these luminal papillary infoldings. So our diagnosis, the right hemiuterus is consistent with hypoplastic uterus with focal adenomyosis seen, and the right fallopian tube is normal, basically. Thank you.
So what is our clinical pathological correlation, the purpose of our CPC today? Okay, so take a moment to digest what you have heard from me earlier about the clinical presentation of the patient, and then what you have heard from Dr. Azyani. Okay, so this is the clinical pathological correlation. Yeah, the hysterectomy specimen of the right rudimentary uterine remnant measured 4 × 3 × 2 and is consistent with the size of a hypoplastic uterus, okay, meaning an underdeveloped uterus. So this is expected in MRKH syndrome. Secondly, there's a small cavity at the center of the specimen with thin endometrial lining measuring 1 mm thick. And there's microscopic examination revelation of focal adenomyosis. So this is consistent with our clinical feature of the gradual collection and disappearance of the very minimal hematometra within the uterus seen on ultrasound. Okay, and as there's an absence of cervix and vagina, when there is continuous bleeding in the uterine remnant, it forms the hematometra, and there will lead to a reflux of blood to the peritoneal cavity through the ipsilateral fallopian tube, which is also known as retrograde menstruation, resulting in the finding of endometriosis and adenomyosis in this patient's specimen. And the small cavity and thin endometrial lining is consistent with reported cases. There are reported cases in literature whereby the uterine remnants have a very low proliferative ability, okay, but normal estrogen and progesterone receptor expression levels. Thus, this resulted in the slow development of endometriosis and adenomyosis. This would explain why the patient only had a raised CA125, which is elevated in endometriosis and adenomyosis, and only a development of a small endometrioma and focal adenomyosis after 22 years. Okay? So this is a very interesting, a very, very rare case. So what is our take-home message? So our take-home message for today is that patients with rare disease may have atypical clinical presentations, and they may have new symptoms and signs that develop gradually over time. As you can see in this case, very interesting. Okay, in the beginning, she was thought to be just a straightforward type 2 MRKH, and eventually, after several investigations and further assessment and progression of disease, we can actually finally see how the disease progressed over 22 years. And patients with rare disease often go through a diagnostic odyssey. It's a journey that they suffer for years before correct diagnosis is made and appropriate management can be carried out. Thus, a systematic approach, which was done in this patient, of history, physical examination, and relevant investigation with consideration of various differential diagnoses, including rare diseases, will eventually clinch the diagnosis. And with that, I thank you. Any questions? Any questions?
Hi, Dr. Esther.
Hi, Dr. Arifah.
I just want
from
to ask
PAG Fellow.
how we break the news. How would you normally break news for newly diagnosed MRKH patient?
Okay, that's a very good question, Dr. Arifah. How we break the news for newly diagnosed MRKH patient. I was just asked this question on Saturday. Okay, breaking bad news or unexpected news, okay, usually you can't run away from the fundamentals, okay? The fundamentals will never fail you, okay? So whatever you are taught in medical school about breaking bad news or unexpected news, stick to it, all right? So, but before we do that, we have to first discover whether we are qualified enough to break that bad news or unexpected news. If we are not at the level to be qualified enough to give information or provide information or answer questions relating to what we are about to disclose, then we ought to call in someone senior to help us with that task. Okay, having said that, what are the fundamentals of breaking bad news or unexpected news? First of all, rapport. Okay, as I always taught you, introduce yourself. Tell them who you are and tell them why you are there so they know what to expect. Okay, and protect their privacy. They may want someone to be with them, but they may not want someone to be with them in the room at that time. We have to ask them how they prefer for this news to be delivered. All right? And then we need to assure them about confidentiality, because this is rare disease, okay? Not everyone can understand it. It comes with a lot of psychological, psychosexual issues. It comes with a lot of psychological trauma, okay? We have to assure them that this is a confidential and we will protect their confidentiality. If they do not wish to inform anyone else or they want to inform their parents or their partner on their own time, we have to respect that, all right? And then last of all, be systematic when you are breaking the news. Go step by step and give them information in bits and pieces. They may not be able to understand everything at the same time. They may break down and cry. They may be silent for a while. This is where your empathetic approach can come in, whereby you can offer them verbal or non-verbal empathetic responses, like giving them a tissue when they're crying, empathizing with them, giving them comforting words, or giving them time, okay? So they may need several visits before they fully understand their diagnosis and the progress of their disease or the expected outcome and the management. You may want to see them again. And in very, very complicated cases, all right, you may need more than one person to break the news, whereby you might need members of your multidisciplinary team to conduct a family conference or a multidisciplinary conference or meeting with the patient, where everybody who has their expert knowledge in this particular condition for this patient will come together and slowly talk to the patient about the further management needed. I hope that answers your question, Dr. Arifa from UM PhD Fellow. Okay, any more questions? Anyone?
Anyone? Any questions? You can come to the mic. Well, registrars, help out here. And then our medical students. So this is a very rare case. And because we are the PAG unit, the most established PAG unit in Malaysia, so we see these cases referred to us a lot. You know, we see about roughly maybe one new case every 2 weeks or so. Sometimes even more frequent than that. Yeah. So Esther, maybe you want to tell them about the MRKH Malaysia?
Okay. So, since you are not asking me any questions, so I will ask you a question. So what does MRKH stand for? Okay, louder. Maya, Rokitansky, Custer, Hauser syndrome. It's named after three scientists. Three scientists. They are very, very intelligent, bright people from the past who discovered things differently, and then eventually, after some time, people correlated and collected their studies and decided to name this syndrome Maya, Rokitansky, Custer. Oh, four of them. Maya, Rokitansky, Custer, Hauser syndrome. Okay, so it's very interesting. So in Malaysia, okay, we have an MRKH support group for these women who have MRKH. Do you remember the TV series Rahima Tanpa Rahim? Yeah, so that is the efforts of the awareness that is being built, okay, to educate people about MRKH, because people don't understand what it's like for a woman to be born without a normally functioning uterus and not being able to have menses and not being able to have a child. As a teenager, she doesn't have any menses at all, so she probably doesn't, she'll probably fast the whole month, and then she probably, prays the whole month. She's always in the prayer room. There's no break for her, and she doesn't buy any pads. It's very difficult for a teenager to be able to go through this. So it's very important to have a support group. And later on, when she comes to adulthood, she didn't know that she has MRKH because everything looks normal on the outside. Right? She's very pretty. She's got normal secondary sexual characteristics. Externally, she looks totally normal. She doesn't know what's wrong with her. She falls in love with Mr. Prince Charming. And then after that, she finds out that she can't have kids. And then when she's so hopeful to have kids, we tell her that she has absolute uterine factor infertility, meaning that she can't have kids at all because there's no uterus. So this is going to be very difficult for them. So it's very important to have this MRKH support group, and we have one MRKH Malaysia support group. Okay, so if you encounter patients in the future, you can always refer them to us so that we can include them in this MRKH Malaysia support group. And in this support group, because they are together, they help each other, they support each other, they don't feel alone. And when they don't feel alone, they are so much happier and they can cope well. We have women in our MRKH Malaysia support group who are happily married, and then they have 1 or 2 or 3 kids. At the moment is by adoption. They're very happy with their kids. And we have gatherings. Sometimes we have gatherings, we have makan-makan together. And then we can see all the husbands, the supportive husbands coming, carrying one baby in one hand and then another baby in the stroller. It's very, very good to have a support group. So there's an MRKH support group that we have in Malaysia. I think they're up to maybe about 80 to 100 members by now and growing. 200 members by now and keeps growing. Okay. Yes,
Esther,
Dr. Hafiz.
is it necessary for us if we know that patient already MRKH by laparoscopic, diagnostic laparoscopic, to do the cryotyping for the patient?
Okay, so this is a very good question, Dr. Hafi, and you have accidentally leaked out one of the questions for the Kahoot and quizzes later. Okay, so there is a diagnostic criteria for MRKH, all right, which is normal hormonal profile, normal karyotype, and normal imaging or normal structures, normal ovarian structures with the absence of vagina and cervix. It can be seen on MRI, doesn't necessarily have to be seen on diagnostic laparoscopy. So you do need to have a normal karyotype because there can be other differential diagnosis, other types of differences in sexual development diseases, DSD, which can mimic MRKH clinically, but they have a different karyotype. They might have 46XY, or they might have other type of sex chromosome DSD. So you do need to fulfill the diagnostic criteria for MRKH and still do the karyotype. I hope that answers your question, Dr. Hafi from Gynae Onco. Yes, Dr. Azyani.
Hi, Doctor.
Dr. Nurul Azyani Haji Rosli.
Hi, Doctor. I'm just want to ask regarding the following the diagnosis of MRKH. So when they know that they don't have uterus, but they have the vagina, but sometimes it's very short vagina. So when do we start? Advise them for vagina dilatation.
Okay, since we have two beautiful PhD consultants here, and Prof. Amelia has already done some talking, so she has earned her salary for today. So we will ask the other beautiful PhD consultant to help to answer this question.
Thank you. I have to earn my salary for today. Okay, thank you, Esther. Thank you, Jenny. All right, for MRKH, some of them have blind vaginas. They might have a short vagina, about 1 or 2 centimeter, but most of the time it is quite flat also lah. All right, so the question was, when do we start dilating? When do we start to create the vagina? The reason we create the vagina is to make sure that later on, when she plans to get married, when she find a suitable partner, at least she can there is some coital function lah. There's some coital function in terms of having a baby. That one we will talk a bit later about uterine transplant and things like that. But it's more of coital function because there are some parents who come in once you disclose the diagnosis to semua. They think that their daughter cannot get married. They don't allow their daughter to get married because they think that tak ada function dah. Okay, but they still hope. There are some kind men, someone like Dr. Sanji, Dr. Hafiz, kind people, all right, that can accept the woman as it is, all right. There are many normal couple that get married, tak dapat anak pun, all right. So you don't actually have to disclose that your partner ada MRKH pun, all right. Okay, coming back to the question, bila, when do we dilate? When do we dilate is when the woman is ready. Previously, the diagnosis of MRKH was made a bit later. They come into to the fertility clinic, ending up to see Prof. Kadir, Prof. Faizal and Dr. Azrai because of fertility punya issue. But now, with all of you here sitting down, now that you know about MRKH, later on when you go out and you practice as a doctor, you're going to make the diagnosis much, much earlier. So we see people even at the age of 16, 17, 18 being diagnosed as MRKH, all right? But their priority is not for getting married, not for having sexual intercourse or anything. They still have things to do. They want to go to college, they want to enter university, get a degree. So by all means, go ahead. There's no reason for you to start asking them to do the dilatation. All right, you do the dilatation when she's ready. Usually, what we tell the girl and also the parents, come and see us. Give us at least 6 months for us to teach them how to dilate. Most of the time, they come to you a week before the ceremony, akad nikah. We can't do wonders. Magic, ting, and then suddenly create. You have to give us at least 6 months. Usually, people will take about 3 months, 4 months for them to be successful. But of course, that's why we don't do in the young girls. You ask an 18-year-old, 17 years old sitting for SPM to do dilatation, tak ada motivation. Dilatation is not without pain, all right? But if you know you're going to get married, you probably do despite the slight pain. So that's why wait until she is ready. If she's going to marry at the age of 33, then start dilating at 33. There's no hard and fast rule that, oh, by 25, you finish college, you must dilate. You don't even have a partner. What's the point of doing the dilatations? But it's for coital function sahaja. Alright? With proper technique, you show them exactly where to dilate. 70 to almost 80% of them are successful. Okay? Even if they're not, because I've seen patients just given the dilator, asked to dilate. Where do they dilate? Right into their urethra. By the time we saw that, urethra was so huge. Because you never advise them. That's why in the PAG clinic, we have the handheld mirror. Show them exactly where the point is to dilate. Okay, so that they know the dilatation is like that, itu semua. Okay, so these are many brands. We don't sell them. We ask them, patient to buy themselves. Alright, if not, PAG kaya dah. Later. Alright, okay, so we ask them to choose which one they are comfortable to use. What if they fail? Doesn't mean that they can't do dilatation. So we've got a good team of people who will help them come into the ward. The doctors themselves will help to do the dilatation. So we give them painkiller, and then the doctor will do round 3 kali ke 2 kali pagi dengan petang. We do the dilatation, and almost about 80% of them success also with the dilatation done by the doctor. Once we created the length of the vagina, after that it's quite easy for the patient to do. Only a very small percentage, but 10% would need operation. Alright, so there are many techniques of doing the neo vagina. The one that we've done, tak ada gambar the Lahu procedure. So dia ada banyak lah dia punya tu. So patient is quite happy, the partner is happy. So does that answer your question? Yes. So I've earned my
Okay. Yes, Dr. Tawa,
Hi, Dr. Esther. Good morning.
mentee of Prof. Amelia.
My goodness. Doctor, I have 2 questions.
Two. Okay.
Yeah. The first one is for the suppress of the menses in a MRKH patient. What kind of hormonal therapy do we choose, and how's the method? The second question is how to advise on fertility in those who are married with MRKH disease.
Okay, so for your first question, you asked how we're going to suppress the menses in a patient with MRKH. So most of the patients with MRKH don't have a functioning rudimentary uteri. So this case that is being presented today at the CPC is a very rare case. It's a subset of a type 2, which is even rarer than the type 1, of a rare disease which is MRKH. Okay, so but in this case, all right, whereby she does have the cyclical pelvic pain, and then we have demonstrated on MRI that there is a functioning endometrium with retrograde menstruation. We did diagnostic laparoscopy and we found that there is retrograde menstruation. Then we can suppress it in the usual way that you guys would normally do. We can use continuous COCP like what we did for this patient, and in fact progestin, which is Visan, if suspecting endometriosis, is also a good option for this patient. But in this patient, cost was an issue for her because Visan is not subsidized and has to be bought by the patient, so she could not use Visan for a very long time, and thus she was only on COCP. That's to answer your first question. I hope there's an adequate answer. All right. For your second question is regarding fertility. So since Prof. Azura and Amelia are here, Prof. Azura and Amelia, would you like to help answer the question?
Okay, I'll do one part and Azura do the second part. Okay, thank you for the question, Tawa. So, of course, these patients, because they don't have uterus, either they have a very small uterus or difficult to see any uterus, or they don't have, very rare cases, they have a small functioning uterus, but it's not connected to a vagina. Yeah. So in most cases, they have a very small uterus. So for some reason, this uterus has not grown, has not developed, even though all parts of their bodies are normal. Yeah. So usually they have what we call as absolute uterine infertility, AFI. Yeah. That means so there's absolute uterine infertility is like women who also, because of PPH, undergo hysterectomy, or women who, because of cancer, undergo hysterectomy. So of course they cannot get pregnant. They're infertile because tak ada uterus tu. Yeah. So in these patients, of course, this is probably the number one cause of psychological devastation for them. That they find it very hard to accept, to process that they're not able to conceive their own biological children. So this is of course a source of. So we've done studies on our MRKH women, and it's not easy for them to wanting to know the diagnosis they don't have uterus, and then to know the diagnosis they're not able to conceive their own children. So memang is very painful for them lah. Yeah. So what we do is when we advise, of course you have to disclose. The way you advise is as Dr. Esther said just now lah, fundamentally with empathy and sensitivity. Yeah. So of course in Malaysia we advise them on adoption. Yeah, a lot of our MRKH women have adopted, and they're very happy with the adopted children. Yeah, so sometimes, in the Holy Quran, Allah has stated, in Surah Al-Baqarah, if I'm not wrong, that Allah will give us you female babies or male babies or both, but there are some where you don't have your own children. Yeah, so maybe you're meant to be the mother or father of this adopted child, for example. Yeah, yang tu pun bawa banyak pahala juga. Yeah, so that is one thing. And then the other thing is, of course, in other countries, they do uterine surrogacy. But in our country, it's not allowed. It's prohibited in Islam and also prohibited legally. Yeah? So uterine surrogacy is, as you all know, is when you give your sperm, your husband's sperm, and then the oocyte, you have the embryo, and then you use somebody else's uterus. Yeah, but that is prohibited in our country. Yeah. Okay, so the next thing that we can do is uterine transplant. So that one I would like Prof. Azura talk.
Thank you, Amy. So about uterine transplant, worldwide, people have been doing uterine transplant and they have shown success rate. The problem with our country is because I think in 2014 ke 2015, JAKIN came out with the fatwa. Fatwa ni for the Muslim is like macam a law lah. So dalam, if you read the fatwa, it is said that it is tidak harus. Tidak harus tu, that means it's best to not do lah. Okay. But then there was one clause inside there that mentioned it was haram. So, but the thing is, uterine transplant, the first uterine transplant was actually done by the Egyptian, by the Saudi Arabian. So these are on the Muslim patient. And if we don't have fatwa that is in our country, usually what we do is we follow the international fatwa, which is from Egypt. All right. But now that is looking back, that means Egypt has allowed, the international fatwa allow. But then our own people, when they make up when they sit down and do the fatwa tu, they came up with the conclusion that it is tidak harus lah, right? So we are having problem in that sense, because I mean we can train ourselves, but what's the point of doing when the country do not allow us to perform? So kita nak perform kat mana kan? Pergi Singapore, pergi Indonesia. So yeah, so that's why Prof Amelia and myself, we are trying to negotiate with JAKIM to ask them to relook at the fatwa with the current evidence that they have. The reason in 2014 when they came up with that fatwa, with that conclusion, is because at that time the first uterine baby transplant pun tak ada. It was at the end. After the fatwa came, baru ada success story to say out there's a live baby born after the uterine transplant. So at that time, when things there was no conclusion, it's still in the experimental phase, so that's why they concluded that way. So now, since 2014, now it's over 10 years, there are almost about more than 90 uterine transplant done all over the world, and then they've got more than 50 babies. So in terms of their success rate, they got better. In fact, we started to engage with Prof. Matt Brandstrom. He's considered the world uterine transplant, and he has the most success story lah. So he started with rat, and then go up to monkey, baboon, and then sheep, and then from there they got the success story. So he came over, I think last year, to teach us about the technique of doing the anastomosis. So we're just waiting for JAKIM to agree agree to relook baru tau. So relook hopefully can change the conclusion. From there, then we can start doing. So the team is actually quite ready, because when I look around UKM itself, we have all the people to do this one. We have the vascular, we have the psychiatric team, we have the immunologists, we have the gynae-onco, we have pathologists. Pathologist dia kena yang spesifik untuk tu lah kan. So kita dah approach the pengurusan, and once we clear the fatwa, then things can start running lah. But for now, what we advise our patient is adoption first lah. Adoption first. Okay.
Okay, thank you. So I think we have come to almost the end of our CPC. I will hand over to our chairperson, Prof. Amelia, to do the closing, and then Mr. Bukhari will torture you with the quiz questions. Okay, thank you very much for your kind attention and all of your interesting questions.
So thank you very much, Dr. Esther and Prof. Zura and Dr. Azyani, who have helped with the CPC, contributed. I hope you all found it very interesting, yes or no? Yes, and then I hope you learned a lot. Yeah, so even though these are very rare, but it's something that you have to keep in mind when you see these patients. Yeah, so in terms of primary amenorrhea, there are many causes. So this is one of the causes of primary amenorrhea. Yeah, and then each case of primary amenorrhea, it's managed differently. Yeah, so just to add, then of course when you're managing MRKH, you have to bear in mind how do you disclose the diagnosis, because if you disclose the diagnosis insensitively, which some of our doctors have done, this causes a long-lasting negative impact on the patient, which they remember forever. Yeah, and then of course, so in MRKH, you have to, as Dr. Esther said, you have to think about disclosing the diagnosis. You have to think about how to counsel them on their sexual function, on their fertility, and then we also, in order to help them, we connect them with the MRKH support group, yeah, and then we give them support, and there's no reason why they cannot go on to have normal, happy lives. Okay, so with that, I thank you very much.